All right, here we go. So yeah, take a picture of that if you want. Those are fair game. So let's talk about, I jacked this up last class. It was embarrassing. So if people are watching it, I'm sorry. Let's talk about this thing called Cushing. Cushing was actually a really busy guy. There's a lot of things named after him, but this is the one we need to know. Okay. So it's called Cushing's reflex. So let's go through our little schematic here and talk about how this happens. So you can have an injury to your brain, right? And that can be from a head injury, a baseball bat to the head, a ruptured aneurysm, hemorrhage, certain types of tumors, stroke, okay? Some type of swelling that increases your intracranial pressure. Think about this, intracranial, inside the head pressure, okay? So it increases the pressure inside your head. And when that happens, there is when this happens, I don't want to even get into that right now. We'll come back to that. I'm trying to figure out what order we're going to do this in. There's a few things you need to know. You're going to have a decrease in pulse rate with an increase in blood pressure. And let's talk about why that happens. When you have increased intracranial pressure, your body thinks, I need to pump harder to get back to that portion of the brain. So the one way it can do that is increasing pressure by squeezing down. If you squeeze down on the water hose, put your finger at the end of it, it shoots further. All right, it's kind of the idea. You're trying to push it further. So when that happens, you have a reflex. So when we raise blood pressure, by reflex, you lower heart rate. Makes sense, right? Because you are going to match cardiac output, right? Because if you squeeze down on the pipes, you don't have to pump as many times a minute. So those two go together. So how will this present? With Cushing's reflex, it's going to sound like this. They're going to have a heart rate of like 48 and a blood pressure of like 180 over 80, right? And their respirations are 22 and irregular, okay? Which I kind of just messed this up. It's probably like 12. Okay, just remember 12 and regular, okay? So let's really talk about this. It starts with increased intracranial pressure. That increases your blood pressure. Now they want you to know that there's widened pulse pressures. What does widened pulse pressures mean? The top number is wide in relation to the bottom number. They want you to know that. This is one of the few conditions this happens in. You will have a very high top number with a fairly low bottom number. That is widened pulse pressures. Hallmark. They want you to know that. Widened pulse pressures in Cushing reflex means a high top number and a fairly low number, bottom number, okay? With that, you're going to get a drop in heart rate. It's going to be low. And because you're pushing on the brainstem, you're going to get irregular ventilations, respirations. Makes sense, right? So this is all intuitive with why this would happen. Now let me ask you this, Dalton. You have a patient, he got hit in the head with a baseball bat, he is unconscious, and these are his vital signs. Do you give him atropine? His heart rate's 48.
No.
No. You do not give atropine to a Cushing reflex patient. It is contraindicated. Makes sense, right? This is the body's reflex. So we do not give it, and they will bait you into this. What they're going to do is they're going to show you the most beautiful sinus rhythm, sinus bradycardia at a rate of 40. They're going to give you a blood pressure of 180 over 80. And they're going to tell you the respirations are 12 and irregular. You're going to gloss over that. And they're going to be like, what do you want to do? And atropine will be the wrong answer. Pacing will be the wrong answer. Okay? That is the wrong answer. Yes?
What do you do?
So you would want to intubate them, right? And transport them. What you don't want to do is be messing with their heart rate. Now, if they go into cardiac arrest, that's a whole different story. But you don't want to be over there giving atropine and pacing to the Cushing's patient. And the reason I'm pointing this out is they trick you with that. They will bait you into this. They'll say, old lady found on the floor, these are her vital signs, assuming she fell and hit her head, increased intracranial pressure. What do you want to do? Right? And they want you to know that she could have trauma to her head. That could be Cushing's reflex, and we don't give atropine, we don't pace.
And you're going to say this in trauma. This is all going to be trauma.
No, trauma. Good point. Trauma, also hemorrhagic stroke.
Okay.
When we bust a vessel in the head, right, an aneurysm, or we blow a vessel in the head, that increases intracranial pressure, right? So why am I saying this? When you see someone that is bradycardic and hypertensive, you need to immediately think, am I dealing with Cushing's? They may not always give you the traumatic scenario. If they're going to be really tricky, they give you low blood pressure or low heart rate, high blood pressure, and they may even just say it's 12, but what I see is sometimes students look over the whole irregular part. They'll just gloss through that, okay? So I need you to know we don't treat this with atropine or pacing. Let them be, okay? Intubate them, control their airway, supportive care, rapid transport to a trauma or stroke center.
And if their heart rate continues to drop, just get ready for
cardiac arrest.
Okay.
Yeah, we don't atropine these patients, okay? It is contraindicated. Good? Now, if they go into cardiac arrest, we do give epinephrine and we just go full-blown cardiac arrest at that point. Everybody good at that?
Yep.
All right. It's an important thing to know. Now, I really quickly want to talk on the treatments. We can get, in some services carry this, and it could pop up in the National Registry, so I want you to be remotely aware. You can give what's called intravenous mannitol. What is mannitol? It's an insoluble sugar. So remember that whole water follows salt, water follows sugar? Well, if we put a bunch of sugar into someone's veins, what happens? You draw water out of the cells. So if you draw a bunch of water out of the cells of the brain, what happens? It shrinks. You buy yourself some time. That's the idea of IV mannitol, okay? Hyperventilation. So I've talked about this a lot. We talk about therapeutic hyperventilation. Okay, so what's the normal end-tidal reading, Ashley? What's normal?
End-tidal?
Yeah.
35, 45.
Yeah, good. 35 to 45 is normal. So what you're going to do is if you intubate this patient and your service tells you to do it, this is not a Hunter-said scenario, but if it's in your protocol, you can intentionally hyperventilate them to get their end-tidal down to like 30. Not 20, but 30. Because what happens is when you hyperventilate, you take out CO2, and when you take out CO2, the vessels squeeze down. When they squeeze down, there's not as much pressure within there. I know that sounds paradoxical, but that's how it works. I'll give you an example. Have you ever wondered why someone passes out when they hyperventilate? It's because their cerebral vessels clamp down. That's why they actually pass out. It is from clamping down of the cerebral vessels. So just the brain vessels clamp down. So just be aware. Elevation of the head, I'm not too crazy about that. That gets a little controversial. And craniotomy. This makes sense. Sometimes if there's a big old blood in there, you have to go in there, drill a hole, and pull out the blood to relieve the pressure. Okay? So just be generally aware of that. Did you have a question?
No.
Okay. All right. So again, this is talking about what can cause them. So you might see Cushing's reflex, which again, bradycardia, hypertension with irregular breathing. Decorticate posturing, disseverate posturing, Biot's respiration, apneustic respirations, chain-Stokes respirations. We just talked about these. These do pop up. Okay? You could have unresponsive or dilated pupil or anoscoria. This is like a non-reactive pupil. So just be aware that we can have pupillary changes as well. Okay? Very important neurological sign. There's a lot of different things that can cause this, Dylan, right? So it can be encephalitis, a ruptured aneurysm, meningitis, tumor, cerebral edema. Pick your poison, right? Lots of things can cause that, okay? Everybody good with that? So, we talked about intracranial pressure. You don't need to memorize this, but I'll talk about it in a second. So, as that pressure rises, you have something pushing on the head. Doesn't matter if it's over here on the outside or in the inside. As you start pushing on the head, the flow to the brain starts to diminish. That would make sense, right? If you start stepping on a water hose, the flow going out the other end will diminish. So, your heart will try to increase the contraction forces initially prior to getting to Cushing's, and then your systolic blood pressure will rise, right? Diastole will fall. So again, systolic rises, diastole falls. That's that widened pulse pressure I was talking about. And then your ability to control your respirate and pulse becomes damaged, right? We start pushing on the brainstem. I don't need you today, you will in head trauma, I don't need you today to memorize these. But do you see this fold right here? And here, y'all see those? Yeah. Those are folds of dura, right? Dura matter that, like there's a fold that goes up underneath here. That they don't move. Just imagine it doesn't move. So what happens is, if you're bleeding over here on this side, it will fold around that dura. And it creates a certain pattern of symptoms that we don't need to know. But like, for example, that's called a cingulate or a subfalcine herniation. What's a hernia of your gut? They kind of protrude, right? Or a hernia into your scrotum, whatever. It's protrusion. So you start getting brain that's protruding around these hard structures, okay? Same thing can happen here. That's an uncal herniation. Or you can have a foramen magnum, right? It can push straight down through the bottom. That would be very severe. But all of these in this cranial vault, it starts pushing on shit, and shit stops working, and the brain stem itself is pushed on. So when that happens, it creates a predictable set of patterns. But I just want you to be aware, there's different patterns of herniation, and they all have their own different signs and symptoms. Everybody good with that? Yeah. Okay. Now, someone asked in the other class, well, Actually, I forgot how they asked that question, so I'm going to talk about that. All right. Now, this one's very important that the National Registry is absolutely positively obsessed with, so let's talk about it. There's this thing called Bell's palsy, okay? And Bell's palsy, gotta know, unfortunately, it's cranial nerve 7, which is also known as your facial nerve. Paralysis. Okay? So it's paralysis of cranial nerve 7. This typically is men, not always though. And there's a very, very important distinction on this. Because this guy kind of looks like he's having a stroke, right? Mm-hmm. But we can tell he's not because his eyeball is paralyzed. Or the area, he can't blink. Okay? And that is how you tell the difference between Bell's palsy and a stroke. As you can see here. In Bell's palsy, which is a lower motor neuron lesion, cranial nerve 7 is jacked up for whatever reason. The whole side of the face, they can't make wrinkles in their forehead, they can't blink very well, they can't make facial expressions, they will usually lose taste, and they will also have what's called hyperacusis. What is that? You know when you hear a really loud noise, how you can kind of make the noise a little bit better? There's a little muscle in your ear called the stapedius that will squeeze down that kind of dampens noise. Well, when that's done by cranial nerve 7. When that's missing, everything's really loud to these patients, so they will complain of that. So this is Bell's palsy. This is Bell's palsy, or it would be this side. See how she can't make any wrinkles in her forehead, she can't move her face, and this guy, see how his eyes looking irritated? It's because he can't blink, okay? So Bell's palsy is complete right-sided or left-sided facial paralysis, everything. Compared to a stroke is only going to be typically from the nose down, so like this section. So that's just going to be the facial droop that's to the side, which could cause slurred speech. Is everybody good with that? You see how that works? They will grill you on this. You have to know Bell's palsy, full face. Stroke, just pretty much the mouth is what you need to know on that. Okay? Why is that? I will just quickly demonstrate this. It's because there's actually two pathways. When you cut the highway down here, that's called a lower motor neuron lesion. So the whole nerve gets jacked up. What's happening in a stroke is you're cutting up one section, but it's an upper motor neuron lesion. It's up here. So you have a redundant flow that will go to the top part of the face. Makes sense? That's why that happens. Okay? There's a reason for it, just let you know. Now, real quick, Lyme disease can cause this. They want you to know that. And you don't need to know about herpes zoster, but you know Justin Bieber? Mm-hmm. You've heard of him. So he has Ramsay-Hunt syndrome, so he had herpes at some point in his life, and the virus can come back and attack cranial nerve 7 to where you get facial palsy. That's why he's not singing right now. And let me make one last thing about Bell's palsy. This can come and go, so a patient could wake up with this tonight or tomorrow morning and be gone in a few days, okay? So be aware. This can come and go. Do strokes come and go? I mean, unless you intervene, typically not, short of a TIA. So where's the difference? What's a really quick way to tell the difference? Bell's palsy typically won't come on just like that. It typically doesn't. It's going to be over at least a few hours, okay? Compared to a stroke, as you can imagine, it's a lot quicker. So if they tell you, guy's noticing weakness in his face that's been progressing over the last week, probably Bell's palsy. Compared to lady wakes up and she has drooping of her lips, right? Probably a stroke. Makes sense? Yeah? All right. That's all we need to know about Bell's palsy, okay? Now, I thought this thing was really confusing, so I really don't even want to spend time on it. I meant to delete it yesterday, but I forgot. So, let's talk about some definitions that they'll grill you on. So just common reality, right? So we have to sense and determine what is real. So, let's talk about hallucinations. So if someone's hallucinating, they're feeling some type of sound, sight, touch, or taste that's really not there. It's in the patient's mind. They're feeling bugs crawling on them, right? They're hearing someone telling them that they're Jesus Christ, right? And for an example, when I talk about religion today, it's not to do with religion. They're common in vignettes. They'll throw this around, okay? So, but hallucination, as you can imagine, someone hallucinating, this one's pretty obvious. I think we know this really well, and it's not hard to distinguish. Compared to a delusion, or thoughts or perceived abilities not based on common reality. I'll give you an example on this. Someone is delusional if they think that the FBI is following them and hacking into their phone. It's believable, but it's unlikely, right? Someone is delusional if they think that there's a military camp living in his attic spying on him. That is delusional. It's believable compared to psychosis. It's not believable, right? So a lot of times in a psychosis question, they'll mention aliens or the Lord or the heavens. So they'll say, patient thinks she's calling Jesus Christ every night at 3 in the morning, and then she transports to visit the aliens on Mars, right? That's not believable, okay? So, and I'm not talking about praying by calling Jesus Christ, but that's what I'm saying. It's not possible. Is it possible the FBI is tracking someone? Yes. So a delusion is one fixed but non-bizarre. It's not bizarre, it's weird, but it's not like, no, aliens, that would be bizarre. But the FBI tracking you, I'll give you another one. They're dating a celebrity, right? Oh, I'm married to Brad Pitt. Could someone be married to Brad Pitt? Sure, unlikely, but it's not necessarily bizarre. I'm married to, an alien that is also known as Jesus Christ or whatever. Right, that's not possible to be married to an alien or, I'm just telling you they love to throw religion into the psychosis ones, okay? Yes.
So we have to differentiate between all three of those. So just for an example, I run a patient who says he has an FBI and a CIA security team that walks him home every day. Would that be delusion?
That's a delusion.
Okay.
He's delusional. It's possible, which is very, very unlikely, and it's not too bizarre. And it's one fixed, right? I'm married to Brad Pitt. That's one. Instead of saying, oh, I'm transporting myself to Jupiter to speak to the aliens and I come back the same night, right? That's too many weird things that can't possibly happen. Make sense?
Yeah.
Okay? Now, and then hallucination.
Yeah.
This could be someone that feels bugs crawling on them, or taste weird things, or whatever. Okay? So these are I will tell you, these are very difficult to distinguish them when they try to make them difficult in vignettes. I'm just trying to hopefully lay some foundation on those, okay? Now, we do you can manage psychosis with medication. So psychosis is common in schizophrenia, right? So we give antipsychotics to schizophrenic people. What are antipsychotics? They block dopamine, okay? So okay, I'll give you an example. Have you ever heard someone tripping out on meth or cocaine and they feel like bugs are crawling on them?
Yeah.
That's psychosis. Same thing's happening in schizophrenia. Too much dopamine, right? So what do? Is we block it. Well, Versed is a benzodiazepine. The actual antipsychotic that's commonly used in EMS is haloperidol or Haldol. Mental Wells carries it. Well, and they should, right? I'm sure they use it every now and then. So yeah,
Okay.
you probably get a pretty similar effect with benzodiazepines, but not the exact. Okay? And then now you're starting to see like olanzapine, risperidone. They have atypical antipsychotics that they're starting to use a lot more, like in the ER and stuff. Ketamine, Versed. We'll talk about dystonias today, but antipsychotics cause some bad reactions. We'll talk about that. Okay. Now let's talk about protective reflexes. So these are reflexes that protect us. Oh my gosh. So they relate to the patient's level of consciousness. So let's talk about the cough and gag reflex. How is a cough reflex protective? When we inhale something that we shouldn't be inhaling, we cough. So if you inhale smoke, what do? You cough. It's a protective reflex. When you when you take a tequila shot, a toxin, what do?
Yeah.
You gag. Some of us, right? But you know what I'm saying? That's the idea. Your body says, ooh, toxin, get rid of it. Okay? Same thing. It's actually the same thing with a hangover. Why do you feel nauseated? Because there's actually a toxin in you. The breakdown of alcohol causes a toxin. And then so you're like, oh God, I should throw this up. Okay? Now, corneal reflex, this one's a little bit more weird, but there's 3 different nerves involved in this. But if you were to take a cotton ball and touch your cornea, the outside of your eye, you're going to blink down instinctively, and that's a reflex. Right? So if dirt gets in your eyes or water or someone's touching your eye, you're going to blink to try to get rid of that. So, like I said, there's 2 chains, but there's 3 different cranial nerves working on this, but it uses 2 different reflexes to test it, okay? Now, I put a few more on here, but these are just cranial nerve reflexes. You don't necessarily need to memorize these, and I don't want to spend any time on them. Just know that there is an in pathway and an out pathway. So, like for example, cranial nerve 5, right, sensation. So when I touch my eye, cranial nerve 5 says, wait a minute, and then it takes cranial nerve 7 to blink down and say, get it out of here. So you just tested 2 cranial nerves in that case. See what I'm saying? So there's value. Yes, Robin?
The name of the in pathway and the name
afferent.
of the out pathway.
Efferent.
Those are very important.
Yeah. Afferent is coming in, okay, and then which isn't always the case in medicine, but afferent is coming in and efferent is going out, okay? I would be shocked, that's probably more of a nursing thing, I would be shocked if they asked it on paramedic. They are? Okay, well she's saying they are, so I would know that, okay? Okay, yeah, I'm all for it. Alright, I thought this was very strange that they want you to know that a protective reflex tapping between a patient's eyes will cause them to blink. I'm not quite buying that one, but they want you to know this, and it's not me writing your exam, so they want you to know that. Now, they say, not Hunter, but they say if patient does not blink or twitch, assume cough or gag reflex is not intact. I don't find this highly sensitive or specific myself, but who am I? So just be grossly aware that this is something your book is talking about, and it dedicated a whole slide to it. That's why I left it in. Now, real quick, I do want to talk about a couple clinical reflexes. So have you ever been to the doctor, and don't memorize these, I'm just pointing out that we have reflexes where they strike your knee and you kick, right? Okay, well, that can tell us if you can kick L3, L4, that spinal nerve is intact, right? And say that doesn't work, or say that one works, then we can hit your Achilles tendon and see if you kick up like that. If that doesn't work, then we know, okay, there's a lesion somewhere between L3, L4, and S1, S2, right? Does that make sense? So that's why we use that. There's another one, the chromastic reflex. So for men, you can stroke the inside of their thigh and their testicles will move up. Testicular torsion, that's gone, okay? So if you don't believe me, you can try it on yourself, not on your partner. Not the person sitting next to you is what I'm saying. Now, this one's important, the anal wink reflex. So if someone breaks their S3, S4 area, and we're wondering, well, are their nerves still intact? Are they still doing what they're supposed to do? You could, with not paramedics, physicians, can put a gloved, lubricated finger in their rectum, their butt, and then pull back, and it should make a winking motion of the rectum. And that's one way to say, oh, that's working. So then you just go further up the chain to figure out where is it broken. Why I'm just pointing out, that is the reason we do those types of tests, okay? So just be aware they exist. Lastly, let's talk about primitive reflexes. So everyone's heard of Babinski sign, right? What's that? It's when you, go ahead.
It's when you stroke the bottom of the foot.
What's normally supposed to happen in an adult?
Aren't you supposed to?
You're supposed to claw down. What happens in a newborn?
Flex out.
They flex out, okay? Why is that? So there's this list of primitive reflexes. I'll give you another one. It's called the Morrow reflex. They'll fall down and they're hanging on for life. The other two is a rooting reflex, to where if you stroke the side of a baby's face, they should start sucking, okay? Looking for a nipple. Now, here's the thing. In babies, their brain is not developed enough to say, don't do that. But as we age, the frontal lobe, right, will say, dude, if someone strokes your cheek, you don't need to start sucking, okay? So it's inhibiting these reflexes. And why does this become important? Because when you have a frontal lobe injury, and I strike the bottom of your foot, and your foot opens up like that, that tells me your frontal lobe is not saying, dude, you don't need to open them up like that. You can squeeze down. Does that make sense? That is why these clinical reflexes become a little bit more important. It's telling you that the frontal lobe is messed up. It's inhibited, okay? So all of these little baby reflexes, the most important one to know is Babinski, the plantar reflex. Again, so if you don't know how this works, if this is my foot, you can take your pen and you just strike up someone's foot like that. You don't do it with a ton of force, but you just strike up. And normally, all of us in this class, their toes will go down. In a newborn baby or someone with a frontal lobe lesion, they will open up. They will go this way. Make sense? Everybody good with that? Okay. Those are primitive reflexes. It's something that you should be remotely aware of, okay? So when you see a paramedic testing that, at least, or a physician or someone or a nurse, at least you'll know what they're doing. All right? Now, pupil area response, I'm actually going to try to write a paper later this summer on this for paramedics, because there's a ton of good information in pupils, but we're not going to spend a lot of time on it today. So, okay, if I shine a light in your eyes, Hunter, are your eyes going to get bigger or smaller? Smaller. They should get smaller, right? They should react, and they should get smaller, okay? So, how many times in ESO do you just hit Perla 3-3 and move on with your day, right? And you're not really assessing them? I do encourage you, at least as a paramedic student, to assess pupils. If I'm a preceptor and I see you checking pupils, my heart gets happy, right? Because I'm like, oh, this patient, they care, okay? Same thing with lung sounds. So at least as a paramedic student, be checking pulse or pupils and lung sounds on every patient. Now, stimulants cause dilation. Is caffeine a stimulant?
Yes.
No! It's not. It's not a medical stimulant. It may make you less sleepy. It's an adenosine receptor blocker. Adenosine makes you feel sleepy, so if you block that, you're not sleepy. But what is a stimulant? Cocaine, which I feel like we talk a lot about in this class. Cocaine, Adderall, meth, those are all true stimulants, okay? Now again, epinephrine would, if I'm about to go fight a bear, I need a lot of light. So it causes dilation, okay? Antichoria, unequals pupils, and so this is the patient where they'll have like a blown left pupil and a constricted right pupil, right? So that's what they're talking about here. It's from increased ICP. You'll see this in the real world. You'll see a patient with a unilaterally blown pupil, okay? Don't get fooled though. I've seen paramedics do Perla with someone with a glass eye. They literally write in their chart, the patient has a glass eye, and they're over there putting Perla in there. I'm like, dude, pupils are equally round and reactive to light, equal, right, to each other. So don't be doing that, okay?
Conversely, there's also a very, very small part of the population that has one that's just ever so slightly bigger than the other. That is also normal.
Yep, and this guy right here, this is pretty extreme, but just be aware that, the chance of you getting cued on that and someone calling you on your crap's pretty low, but just be aware that there are variations. Same thing with cataracts, and there's different eye pathologies and stuff like that, all right? Why did I leave this in here? It seems too simple, but I've asked y'all this before and you struggle. The normal blood glucose reading is 60 to 120. If it gets below 10, it's usually fatal. Makes sense. Your body needs glucose to produce energy, to produce ATP, right? But below 30 or above 300 will usually cause confusion. Makes sense, right? Not enough glucose, you start getting confused, okay? Could you have confusion at 55? Yeah, absolutely. Could you have it at 65? Yeah. Absolutely, okay? So just be aware that those are generalities, all right? Now, these are these super annoying cranial nerves. I will zoom in on this and you can take a picture of them if you want. I wouldn't say you need to memorize all of these or everything on here, but it's fairly useful to know some of these, okay? Just be remotely aware that they have different functions, right? So, whether it's smell, sight, your eyes, sensation, eyes, facial movement, hearing, tongue, this does a lot. Coughing, gagging, accessories, turning your head, shrugging your shoulders. So just be generally aware. Now, there are a couple conditions on here that come up very often. One of them is trigeminal neuralgia. I had a paramedic student when I was teaching at Weatherford College that had this. So your trigeminal nerve has 3 branches, right? It's one of the few that has branches, cranial nerves that have branches. In V2, cranial nerve 5, but the second branch goes right through here. And just blowing of the wind, right, or a piece of hair striking your face will cause extreme pain for about 15-20 seconds, like a lightning bolt to your face, just shooting pain. And that is trigeminal neuralgia. It is sharp, short, unprovoked pain in the face, usually on the upper cheek. It can be on the lower jaw as well, but it's typically the second branch right here. And it is extremely painful, and your book mentions this about 5 times in this presentation, so you need to know this is cranial nerve number 5, or they'll also write it cranial nerve V, which is 5. So just be aware, okay? We'll talk a little bit more about this later, but we're going to lay the foundation. Now, this other one, myasthenia gravis, this is an autoimmune condition. I actually want you to write this down. When you hear autoimmune, I want you to think 20 to 40-year-old female. Not my opinion, but the classical vignette of an autoimmune syndrome patient is a 20 to 40-year-old female. So a lot of times they hand that to you in the vignette. They'll tell you that as the age, and that's what they want you to know. So what is myasthenia gravis? Some people will call it gravis. I don't care. Myasthenia gravis. It's a neuromuscular condition that causes weakness. So I told you acetylcholine has to do with the parasympathetic nervous system, right? Right?
Yes.
It also has to do with muscular contractions. So what happens in myasthenia gravis, you have an autoimmune attack against acetylcholine. Okay? So your body attacks it's actually your acetylcholine receptors. That should be clear. So think about this. If your body is attacking your acetylcholine muscular receptors, what are you going to present with? Weakness. They get weak. Okay? So they present with weakness, but what's interesting is it gets worse throughout the day. That's a hallmark thing that they might tell you in the vignette. The weakness gets worse as the day goes on. And that is myasthenia gravis. It's an autoimmune condition where the body attacks its own acetylcholine receptors at the neuromuscular junction. Typically a 20 to 40-year-old female. It's an autoimmune condition. That's what I need you to know about it. Everybody good with that? Yeah? Now, one of the interesting tests, and the reason this is on the cranial nerve function, is they have a hard time keeping their eyes open for a long period of time, and one of the tests we do to test for this is you ask the patient to look up for 60 seconds. So you'll raise your hand up and say, look at my finger, and you'll see how long they can look up, because their muscles will get weak in their eyes, and they can't do that very long. Okay, so that's just one of the tests. That's why it's on the cranial nerve function one. Good? Good? Moving on. Alright. What? Oh, yeah, we'll probably get tired of looking at it. But yeah. Probably not though. It's usually females. So, real quick, just talking about speech. I don't even want to talk. This is what I was looking for. You got to notice the patient does speak clearly, but they don't give correct answers. That's one thing. Notice the patient can't follow commands. But I want to talk about this whole aphasia thing. So aphasia means a language deficit. And they will straight up throw this word at you, but I want you to notice the spelling. It's with an S. This S happens to stand for speech. Because aphasia is difficulty swallowing, gulp with a G. There is a difference between the two, and you'll get a question wrong if you don't understand the two. So the S in here is for speech. Okay? Now, with that said, aphasia means that you have some type of language deficit. Now, there's two that surprisingly your book doesn't hit really hard on, but it's actually important for paramedics to know. And it's called Broca or Wernicke's aphasia. So Broca's aphasia is actually right here on the brain. It's on the right here. It's at the temporal region, okay? And what happens on this one is these are the patients that have, as the mnemonic, a broken boca. Boca means mouth in Spanish. So it sounds like this. I actually took care of a lady when I used to work in a nursing home in high school, and she goes like this. Do 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 do. And she's telling you, I want to go to the bathroom, I don't feel good, and that's all she can say. Her mouth is broken, but she knows what she wants to say. And since she can't say that, and she has insight, she becomes very frustrated because the rest of the world does not understand her. So, again, she was like, okay? That's Broca's aphasia. The hallmark of this that you should know is the patient has insight and they appear frustrated because they cannot communicate. How frustrating that you can't communicate. Now, Wernicke's aphasia, this happens further back here, near the parietal section. And let me also say that Broca's aphasia is most common. Okay, most common cause. And these are due to strokes, by the way. That's why we're talking about them. Wernicke aphasia is word salad. So you may ask a patient, hey, what do you want for lunch? And they might say, green flower, red Toyota wheel tire car. And you're like, what? And they'll say, yellow, orange, red, flag, cherry, tomato. And you're like, what? Yeah, so it's word salad. They can say the words. Their tongue and mouth can make words, but they don't make sense. Word salad. But what's bad about these patients is they don't have insight. So they're not frustrated. They can't produce speech. Okay? These are very difficult, I will say, but I want you, because you actually see, I'm sure you've ran stroke patients where they sound like this. They will actually have jacked up speech in these disorders, okay? So just be generally aware these exist, and these happen from strokes. Different arteries get occluded, you get different patterns in these, okay? Everybody good with that? Mm-hmm. Okay, moving on. Now, they will drill you on this. Hemiparesis is weakness of one side. Hemiplegia is paralysis. So a quadriplegic, right? They're paralyzed. So hemiplegia is full-blown paralysis versus hemiparesis is just weakness. And you have to know the difference between those two. They grill you on it. Okay? Now, this last line right here is really important. Whoops, I jacked all that up. Okay. Patients may have weakness on one side of the face and facial droop on the other, or body weakness on the other. These are brainstem strokes. If someone brainstem infarcts, they can have right-sided facial droop with left-sided hemiparesis. Okay? Why is that? Remember the cranial nerves? They don't have to cross. So the ones going to your face, they're fine. But the ones that go down, they will decusate. So that's why. So You don't need to know exactly how that happens. Just know that you can have right-sided facial droop with a left-sided hemiparesis hemiplegia. Makes sense? If they tell you that, they're throwing you a bone. It's a brainstem stroke, okay? They will never ask you what type of stroke is this. I'm just letting you know for the pathophys, the brainstem stroke, it's still a stroke, it's still treated as a stroke, okay? Makes sense? These are fairly rare. Good. All right, moving forward. Now, we can do cerebellum test. I just want to make a couple points. So if I were to ask Hunter to come up here and say, here, we'll just do it. Touch my index finger with your index finger. Keep doing it. Right? Mm-hmm. But if his cerebellum isn't working, when I throw up to his finger, he's not going to be able to get it there because he can't coordinate getting it there in time. Makes sense, right? Almost like his own finger to nose test or asking him to walk a line, right? Those are all cerebellum tests. Makes sense? Another one that we do, and you probably didn't even realize it, is pronator drift. So if you ask a patient to hold out their arm and close their eyes, what might happen? Their GPS may not be telling them that this thing's falling. Makes sense, right? So that is a test we can do for cerebellum. Another one we do is called dysdiadokinesia. You can ask the patient, flip your hand back and forth as fast as you can. In a patient with Parkinson's disease, Huntington's disease, they cannot do this because it takes coordination to turn this muscle off and turn this one on and to do it quickly. So if they have a cerebellar insult, it looks like this. Right? It doesn't work. They cannot. And what's sad is the faster you ask them to go, the worse it gets. Okay? So I'm just letting you know there's different cerebellar tests. You don't need to know all of them, but when you think cerebellum, the back bottom part of the brain, you need to think GPS coordination. Everybody good at that? All right. Now, gait refers to walking patterns. So if someone has a jacked up gait, they have a hard time walking, whatever the gait disorder could be. Okay? But ataxia, there's a reason this is bolded, is alteration of the ability to perform coordinated motions. Okay? So they love to throw this word around in your vignettes. You've probably already seen it before. Ataxia means they cannot do coordinated motion. Okay? Now, you could ask the patient to walk several steps and see if they walk in a coordinated motion or if they are not steady on their feet. They might walk real rigid, or they might walk with a stomping gait because they don't know where their feet are in relation to the ground, right? There's all sorts of disorders that could happen. They might shuffle. There's all sorts, okay? Now, we should be able, the patient should be able to compensate to keep from falling, of course. Everybody good with that? That's cerebellum. Now we're moving on to bizarre movements. So, me and Jeffrey and a guy once doing this. Myoclonus. So remember that whole reflex hammer to the knee? Remember that?
Yep.
Right? So there is a condition where it's like that, but it's sustained. The knee will just stay out and reflexing. Okay? But you can do this to people's wrist or hands, commonly is how we assess it. So it looks like this. I will take someone's wrist that's relaxed, and I'll take it and I'll yank it back. Not break it, but yank it back. And it stretches the tendons in there, and just like when you hit it with a hammer, it'll start pulsating like this. As long as I'm putting pressure on it, the wrist will bounce. And bounce and bounce and bounce. And then when I let go, it'll stop. I could do the same thing with their foot. So someone could take my foot, push it forward, and then kick it back, and it's going to rhythmically bounce until I take my pressure off of it. That's myoclonus. It's rapid, jerky muscle contractions. Okay? It can occur involuntarily. In fact, hiccups is an example of this. You know hiccups? Mm-hmm. Myoclonus. But this also can mean an upper motor neuron lesion. Something's wrong in their brain. Okay? So be aware, me and Jeffrey and a guy a long time ago in Alito, that he had that. I didn't know it at the time. We got to the hospital, the doctor starts testing for myoclonus, they end up tubing him. But long story, what I'm letting you know is this is something that you could assess. It means hyperreflexia. They're too reflexive. Just like when the hammer hits your knee and you kick once and you relax, what's happening is the hammer's hitting them and they're staying kicking because they're overreacting. Now dystonia, we're going to talk about this a lot, but what is muscle tone? Muscle contraction, right? Dys means wrong, so it's the wrong muscle contraction. So they can end up with something called torticollosis, where they're kind of locked up, right? That's what they're showing you here. Their hands can get locked up. They might get in a weird shape. There's different causes of this. We'll talk about this more moving up. I just want you to know dystonia, the part of the body will remain contracted and it stays contracted, okay? We'll come to this. There's a treatment to this that you're never going to believe, but it's Benadryl is how you fix it, which is weird. But, all right, rigidity, stiffness, emotion, that makes sense. I need you to know there's different types of tremors, okay? In Parkinson's disease, they have a rest tremor, okay? So at rest, they're tremoring, right? They'll do pill rolling, or their head will be bouncing, or something to that effect. It happens at rest. That's one way that can happen. Another way this can happen, it actually happens to my brother's wife's dad, who's a sweetheart, and when he eats with intention, he's intentionally using his muscle, his tremor gets worse. So it's very sad. When he writes or when he eats, he's trying to eat like this. So imagine bringing soup up to your mouth like that. Very difficult, okay? You've probably seen this. It runs in families. It's called benign essential tremor, and it's treated with alcohol, oddly enough, so they tend to be alcoholics because alcohol increases GABA. GABA increases inhibition. So that's one way that can happen. I'm just giving you examples. In postural tremor, this is kind of like, again, this would be like Parkinson's disease. They have tremor in their posture, okay? So this could be, people that are tremoring in their posture, all right? We're going to talk about seizures, but I just want you to know generally about tremors. Everybody good with that? Good? All right. Now, how long have we been going? 40 minutes? Do we need a break? Let me see what slide we're on. Oh, shit, I better speed it up. Well, maybe not. 1 second. No, we're about to, let me just see one thing. We're about to take a break, but let me. Yeah, let's actually take a break and come back at 2:20. Everybody good with that? 10 minutes? Okay. We're through the foundational stuff. Now we're going to start kicking through pathology. All right?